Every effective medication has side effects. The good news is that for bone protective drugs, serious side effects are uncommon, but they are real, and knowing what to watch for and how to prevent problems makes all the difference. Let's start with hypocalcemia. Hypocalcemia means low calcium in the blood. All anti-resorptive agents, bisphosphonates, denosumab, and romosozumab, can cause or worsen it because when you suppress bone resorption, you reduce the release of calcium from bone into the bloodstream. Who's most at risk? Patients with pre existing vitamin D deficiency, patients with reduced kidney function, patients with malabsorption disorders, patients on denosumab. This drug has the sharpest rank ligand blocking effect and the most pronounced calcium lowering action. What are the symptoms of hypocalcemia? Well, you can have muscle cramps or spasms, tingling or numbness around the mouth and the hands and the feet, muscle twitching, it's called tetany. In severe cases, cardiac arrhythmias and even seizures. What are the key steps for preventing all this? For all patients starting anti-resorptive drugs, we need to check 25 hydroxy vitamin D levels and correct any deficiency to at least 30 nanograms per ml before the first dose. We need to ensure adequate calcium intake of about 1,000 to 1,200 milligrams daily through food and supplements combined. Check the renal function, creatinine, EGFR before IV bisphosphonates specifically. For denosumab specifically, the rebound when stopping includes a calcium spike. Transitioning to a bisphosphonate helps mitigate this spike. Healthcare providers, listen up. Vitamin D deficiency is extremely common in this patient population. Do not skip this check. Starting denosumab or zoledronate in a vitamin D deficient patient is a preventable cause of clinically significant hypocalcemia. Now let's address osteonecrosis of the jaw. Medication-related osteonecrosis of the jaw is a condition where bone in the jaw fails to heal properly after trauma, most commonly after tooth extraction or other invasive procedures like implants. Exposed bone that doesn't heal can lead to pain and infection. And why does this happen? Bisphosphonates accumulate in the bone long term. In the jaw, where the bone turnover is high due to dental activity, suppressing osteoclasts too much can impair the normal healing response after dental work. So how common is this? In the lower doses used for fracture prevention compared to the very high doses used for bone metastases, the risk is low, around 0.05% after 5 years and 0.18% after 10 years in osteoporosis treatment. In breast cancer bone protection studies, it's about 0.3 to 1.2% for bisphosphonates. The benefits of anti-resorptive medications usually outweighs the risk. Is there anything you can do to prevent it? Well, you can complete any dental work before you start anti-resorptive therapy. Also, make sure to maintain excellent oral hygiene throughout the whole treatment. Tell your dentist that you are on these medications. If elective invasive dental work is needed during treatment, use prophylactic antibiotics, local and systemic, and avoid unnecessary invasive dental procedures. Patients should know this does not mean that you never go to the dentist. Routine cleanings, fillings, non-invasive procedures are fine. The concern is primarily with extractions and implants. What about atypical femoral fracture? Long-term use of bisphosphonates has been associated with a rare type of fracture. It's called an atypical femur fracture. It's a break in the shaft of the thigh bone in an unusual location, often with minimal trauma, sometimes preceded by weeks of thigh pain. How rare is this? It's very rare, approximately 1 in 10,000 persons year of treatment. To put that in perspective, bisphosphonates prevent many hundreds of fractures for each atypical fracture they may cause. The benefit to risk ratio strongly favors treatment. The patient has some warning signs to report, like new or unusual pain in the thigh or groin area. This should prompt X-ray assessment immediately. Clinical note: fear of this side effect has led some patients and some clinicians as well to avoid or to stop bisphosphonates prematurely, and this is a problem. The risk of not treating osteoporosis far exceeds the tiny risk of this complication. What about the acute phase response? With the first IV dose of zoledronate in particular, many patients can experience a flu-like reaction within 24 to 72 hours. They can have fever, muscle aches, fatigue, bone pain. This is called the acute phase response, and it occurs because bisphosphonates trigger a temporary release of inflammatory cytokines. It is not an allergic reaction, and it typically resolves within 2 to 3 days. It is much less common with subsequent doses. Can you minimize it? Yes. A 3-day course of dexamethasone, which is a low-dose steroid, taken around the time of the first infusion significantly reduces the severity of this reaction. This has been confirmed in a recent randomized controlled trial. Taking Tylenol and staying hydrated also help. In episode 4, we introduced the 2 PTH-based anabolic bone drugs, teriparatide and abaloparatide. Their side effect profile is quite different from the anti-resorptive drugs, and it is worth covering carefully because patients and providers who are familiar with the bisphosphonate side effects may not anticipate what to expect from anabolic therapy. The most important conceptual shift: whereas anti-resorptive drugs suppress bone breakdown and can lower blood calcium, causing hypocalcemia, the anabolic drugs stimulate bone metabolism and they can raise blood calcium. So you have hypercalcemia, not hypocalcemia. That's the direction of concern here. So let's talk about hypercalcemia and hypercalciuria. Both teriparatide and abaloparatide increase calcium absorption from the gut and calcium release from bone as part of their anabolic mechanism. This can lead to elevated calcium in the blood, hypercalcemia, and elevated calcium in the urine, called hypercalciuria. Hypercalciuria in particular raises the risks of kidney stones. So patients with a history of kidney stones, pre-existing hypercalcemia, or primary hyperparathyroidism should not use these drugs. Serum calcium should be monitored during treatment, especially in the early months. Abaloparatide was specifically engineered to have less calcium mobilizing activity than teriparatide, so that the hypercalcemia risk is somewhat lower with abaloparatide, but it is not zero. Now, what about orthostatic hypotension? Both drugs can cause a drop in blood pressure upon standing. It's called orthostatic hypotension, especially in the first few hours after injection. Patients should be counseled to sit or lie down for a short period of time after administering their daily injection and to rise slowly. This effect tends to lessen over time as the body adjusts, but it's especially important in older patients already at risk of falls. Somewhat paradoxically, a drug given to prevent fractures by building bone can actually increase fall risk through this mechanism if the patients are not warned about it. What about nausea, dizziness, and leg cramps? These are common, they're generally mild, and most pronounced, again, early in treatment. They typically improve with continued use. Taking the injection at bedtime rather than in the morning can also help, as any dizziness or nausea occurs during sleep. Now, the osteosarcoma question. This deserves careful, balanced discussion because it is the side effect that patients most frequently ask about and most frequently misunderstand. In rat studies at very high doses given over the entire lifespan of the animals, teriparatide was associated with osteosarcoma, which is a rare and aggressive bone tumor. This led to a black box warning on teriparatide for many years. However, and this is critical, the doses used in those animal studies were far higher than human doses. The animals were exposed throughout their entire lifespan. And in over 2 decades of human use with millions of patients, there has been no causal link between teriparatide and osteosarcoma in humans. The FDA has actually removed that black box warning from teriparatide that happened in 2020 based on this post-marketing safety data. The 2-year lifetime cumulative use limit for teriparatide and abaloparatide combined remains in the prescribing information as a precautionary measure, but it is not driven by confirmed human evidence of harm. Patients who ask about this deserve an honest answer, a calibrated answer. The osteosarcoma concern arose from animal data. It has not been confirmed in humans despite extensive use, and the FDA has removed the black box warning. The 2-year limit exists as a reasonable precaution. The risk of not treating severe osteoporosis in terms of hip and vertebral fractures, disability, and mortality almost certainly exceeds any theoretical osteosarcoma risk at approved doses and duration. Now, contraindications to know. Beyond kidney stones and hypercalcemia, teriparatide and abaloparatide should not be used in patients with Paget's disease of the bone, unexplained elevated alkaline phosphatase, a history of skeletal radiation therapy, or bone metastases, because in these settings, the anabolic stimulation of burn turnover could be harmful. Side effect summary for the full medication landscape: anti-resorptives, anabolics, and dual action agents. First, hypocalcemia. The primary concern is with bisphosphonates and denosumab. Check and correct vitamin D before starting. Ensure adequate calcium. Monitor renal function. The risk is highest with denosumab, especially in patients who have kidney disease. Medication-related osteonecrosis of the jaw, it's rare at prevention doses. Dental check before starting any anti-resorptive. Good oral hygiene throughout. Inform your dentist about all bone medications. Atypical femur fracture, also very rare with bisphosphonates, approximately 1 in 10,000 person years. Report new thigh and groin pain promptly, and don't let the fear of this side effect prevent appropriate treatment. The acute phase response is common after the first IV zoledronate infusion. It's manageable with dexamethasone premedication, acetaminophen, and hydration. Rarely a problem with subsequent doses. Cardiovascular risk with romosozumab, there's a black box warning. Screen carefully. Do not use in patients with recent heart attack or stroke. Must be followed by anti-resorptive therapy as well when the 12-month course comes to an end. Teriparatide and abaloparatide, these are the anabolic drugs, and they go in the opposite direction from the anti-resorptive drugs. Watch for hypercalcemia and hypercalciuria rather than hypocalcemia. Monitor serum calcium and counsel about kidney stone risk. Take the daily injection at bedtime to minimize any dizziness, nausea, and also leg cramps. And be aware of orthostatic hypotension. Sit or lie down after each injection. Rise slowly. That's especially important in older patients who have a higher fall risk. The osteosarcoma concern is based on animal data only, has not been confirmed in humans, and the FDA has removed the black box warning back in 2020. The 2-year lifetime limit remains as a reasonable precaution, not as a confirmed human safety signal. In the next episode, putting it all together, we will look at who should be screened, who should be treated, and what the complete clinical algorithm looks like in practice. See you soon.